Everybody, it's 4 p.m. in Italian time, so it's time to get started with Food for Veins. As always, we will welcome 10 seconds in order to allow everybody to join in. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and welcome again everybody to Food for Veins and Veins for Food, an educational and also humanitarian initiative that starts always with the art and with the heart of Monica Glowinski in honor of all the health professionals who have shown such a good art during this COVID time, because indeed the project is aimed also in supporting post-COVID economic crisis as requested by the recent Lancet journal publication. Nothing would have been possible without a truly stellar army of world-renowned key opinion leaders, and also thanks deeply to all the ones who followed us last Sunday and will remain with us. So deeply thank you, of course, also to the stellar faculty in particular of last Sunday, and thanks twice because they also spent extra time during the week to answer to all the questions that have been reported during the live webinar in the written form, because of course we cannot answer to all the questions. So you can find the answers published, available in the web page, and feel free today as well to ask whatever you want in whatever language, and be sure we will reply. Today we focus on venous ultrasound. Also today you will be eligible for international CME accreditation and also Italian CME credits. We could not find somebody bigger than this, of course, in talking about the venous ultrasound. So we will properly thank later on the two keynote speakers, Professor Labropoulos and Professor Black. I'd like to take this chance to deeply thank also the masters of the recorded video lessons, so top professionals who already contributed with recorded videos you can find in the website, and the idea is that you can enjoy them before attending the webinar, so to have a common knowledge on the topic. So deeply thank once again to Professor Labropoulos, to Professor Diane Newhart, and Professor Cheese Wittens. These gentlemen and gentlewomen will also serve as honorary chair of the session, and they will be so nice to wrap up in 5 minutes the take-home messages we should all take home after this webinar. But not before having enjoyed, of course, the scientific word round we will have in 10 minutes after each keynote speaker, thanks to the Continental top experts representative that later on we will recognize one by one and thank one by one. As always, nothing would have been possible, again, without the world-renowned key opinion leaders faculty, the individual donors, and what we define the Magnificent Seven, so the 7 companies who worked with us on this project for supporting that with unbiased grants. So Amnol, Balton, Bayer, Medi, Servier, Sigvaris, Tactile. Thanks to all of you. And let's hope to be all together soon for a food moment, this time not in terms of humanitarian support, but in terms of social gathering. I will take 20 seconds to say that it would be nice to be together during a dinner tonight, also with a birthday cake in honor of our Khaled Zidane, who is also representing all the ones we don't see during these webinars, but are fundamental to make everything possible. As always, it's not just where you go, but also who you are traveling with. And then I will pass the mic to the friends and colleagues I chose as a family. So Oscar, the mic goes to you. Unmute yourself, Oscar.
Now?
Yes.
Perfect. Thank you to everyone for your participation in this important event. One more time, and I want to mention the Latin Americans will be able to make questions in Spanish. Pueden hacer sus preguntas en español, todos aquellos de habla hispana. Gracias a todos por su participación en este importante evento una vez más. Let's start this wonderful meeting.
Gracias, Oscar. Now we move all the way to California with the opening of Professor Chi. Willie?
Thank you, everybody. Thank you, faculty. Thank you, friends from around the world. Some of you is midnight, some of it is early in the morning like I am, some of you is afternoon. But let's go ahead and enjoy the next hour and a half and learn a lot.
Thank you so much. So I will share my screen again because we have a special moment now for introducing Dr. Mina Sherian. As you know, we have always a guest of honor who is involved in the venous or lymphatic ward, but in a not totally overlapping way, meaning that they are not a specialist of the venous and lymphatic ward. This time we have a huge guest. Professor Mina Sherian is the president of the Geneva Foundation for Medical Education and Research, and she has always also been the developer for the World Health Organization of a global initiative for emergency and surgical care. The idea is to have us opening the meeting because of the importance of venous and lymphatic disease that has to be put on the table of the big institutions for public health awareness, of course. So Dr. Sherian, thank you so much for being here with us, and the opening is yours.
Thank you, Dr. Sergio, for this privilege, giving me this privilege to be part of the Global Education Initiative and humanitarian support with the objectives of the universal health coverage. Being an anesthesiologist with my past experience also as an obstetrician and my most recent work with the global public health, I understand very well that if the treatment for venous conditions is neglected, they have a huge impact, both quality of life and on the society. It is one of the leading causes of death and disability in low and middle income countries, where the vulnerable patients have inequitable access to health services. I congratulate the V Foundation for bringing together global expertise and participants during this challenging COVID environment to share and exchange updates in this discipline. Good evening and good morning wherever you are, and best wishes to all from the Geneva Foundation for Medical Education and Research. And also I would like to add happy World Blood Donor Day today.
Thank you so much. I will share my screen again because now we are getting into the scientific part of the initiative. And as always, it's quite difficult to introduce such stars because introducing Nikos Labropoulos, last time we were talking about classical music. Here we are talking about giants of the rock and roll music. So it's like introducing a Bruce Springsteen in my mind. I will just try to sum up the huge curriculum in a very fast way, saying that we know that he is head at Stony Brook University. We know that among friends we call him Nicopedia, like Wikipedia, because he basically knows everything in terms of science. I think always that the ones near to us are our ID. And I have to say that the only one who very probably will be able to beat him is his daughter, that is an example of genetic brightness, I would say. Is such a nice person that I could not present it just by myself, but Oscar insisted in presenting him as well. So Oscar, I will leave the mic to you for a second and then we'll go to Nikos. Thank you.
Thank you. I don't want to be repetitive mentioning what Nikos represents for the specialty. Since I have been very close to him as a friend throughout his extensive career, I just want to highlight the importance that Nikos has for Latin America and what his presence has meant in the growth of inter-university meetings, as he has been with us at the start of these meetings since 2007. Thank you.
Thank you, Oscar. Now, Nikos, the floor, even if virtually, is yours. So if you want to share your screen and start your presentation. Nikos, unmute yourself, or Khaled, unmute Nikos, please.
Perfect. Can you see my screen?
Yes, perfectly. We are ready to go.
Hello, everybody from around the world. Thank you for your kind words, and thank you for allowing me to participate in this wonderful event. I'm going to focus my talk on the evaluation of ephemeral obstruction, and it's really a privilege to have the floor together with my good friend, Steve Black from London. When we're thinking about venous obstruction, this could be intraluminal, extraluminal, or both. And of course, it's going to be acute because of thrombosis, chronic because of thrombosis or compression, or both. Whatever the cause, this increases the venous outflow resistance that leads in most of the people in chronic symptoms of venous disease. Now, here is an example of a patient with chronic iliofemoral obstruction. We can see the common femoral and external iliac arteries, the head of the femur, but here the vein, right, has no flow. Patients with such great obstruction, the higher incidence of PTS, they're more likely to develop venous claudication with an incidence of about 20%, and also they have 2.5 times higher chance for recurrent DVT. When you get the recurrent DVT, you expose yourself again to the threat of getting a PE and dying, but also ipsilateral recurrent DVT increases the incidence of PTS significantly. It is also evident from multiple natural history studies because of the large clot burden, these veins do not recanalize as easily as the femoropopliteal and calf veins. And therefore, obstruction in these veins is more common. Now, a few things about extrinsic compression. And as you see here, we have compression of the common iliac veins by the right common iliac artery on the left, by the right common iliac artery on the right, and by the left on the left. And of course, the external iliac veins with multiple combinations you see here, or one of the above. And that's why we should abandon the term May-Turner syndrome, which is medically, right, inappropriate and historically inappropriate. We just published in our recent paper a month ago the whole story of the iliac vein compression. It did not start by Virchow, as many people claimed in 1851, because in this paper, the word iliac vein is not mentioned anywhere. The first description was done by Dr. McMurrich, which was a Canadian zoologist and anatomist when he was working in Ann Arbor University in 1906. And there are several papers before May and Turner said exactly the same things like these guys did before. Now, when we look now to evaluate, there is direct criteria with the ultrasound and indirect. The direct involve planimetric diameter stenosis, basically putting calipers like you do with the angiogram, the venogram, or the IVUS. A velocity ratio, which is the velocity before and after the stenosis, and luminal changes such as the occlusion of the vein, intraluminal webs, wall thickening, reduction in diameter, etc. The indirect findings, which people are familiar, include non-phasic flow in the proximal common femoral vein, asymmetrical flow pattern in the common femoral veins, non-phasic flow during Valsalva maneuver, low or no velocity augmentation in the common femoral vein, presence of collateral veins, reverse flow in the ipsilateral internal iliac vein, cephalad flow in the inferior epigastric vein, reverse flow in the deep external vein, and difficulty into compressing the common femoral vein due to the high venous pressure. Let me remind you that identifying obstruction, it does not give you license to treat, because currently many people that a finding of an obstruction or particularly iliac vein stenosis and perform treatment inappropriately in many patients. Now, ultrasound is the most operator-dependent technique. Therefore, rigorous training and experience are necessary, particularly in the iliac area of the pelvis, as the people are not very familiar. Here are a few examples of a normal flow pattern on the top left, interruption of the flow with the Valsalva maneuver, flow augmentation with compression of the thigh, and here you see vein collaterals with non-phasic flow indicating obstruction. Now, non-phasic flow is diagnostic for obstruction proximal to the imaging site. However, a normal waveform cannot exclude proximal obstruction. And here is an example for one of our patients showing non-phasic flow and asymmetry because of the left iliac obstruction. Here you see what you see is the left deep external patellar vein that's very high flow and is reversed, and very low flow of the common femoral vein, which is not non-phasic. And look at the comparison now between the left and the right. The right has more flow and is phasic. So that's asymmetry, right? So now when we check in this system, regardless if there is obstruction in these particular veins, we always check the inflow very well. And the inflow is defined by the common femoral iliac union, which is the femoral vein and the deep femoral vein. That's extremely important because if a procedure was to be made, particularly a stent to be placed proximally, then adequate inflow has to be provided by any of these veins. Currently, we don't have criteria of what is adequate inflow for placing a stent. And here is an example on this video you see. This is a slow flow that the blood is moving when you really push the thigh hard, is because a patient has a proximal iliac vein obstruction. Sometimes the same phenomena can be observed in pregnant females, particularly after the 6th month, as the fetus can compress the iliac vein most often on the left side. And here is one example in our own hospital. A few years ago, the patient had lack of compressibility of the common femoral vein, you see here. And you see, they're almost collapsing the artery and the vein does not collapse. But this is because the pressure was very high. And you can see here on the video, if you put really high pressure, you can really collapse the vein. So you have a false positive finding because of a high venous pressure. But when you see this, it indicates proximal venous obstruction. Here is an example of what happens when you have poor inflow. One colleague of mine, early in his experience, he put a stent on the patient that obviously thrombosed, you see here. And the reason is because the patient has no good inflow. You see the common femoral vein, the femoral vein, and the profunda are severely compromised. And compare this flow here on the left to the right, is beautiful flow, and that's why the stent failed. Placing the stent, the technique was accurate, but the problem is the patient has no adequate inflow. And that's why the stent occluded, and this is a very common reason for stent failure. Here, this patient has some light compression from the right common iliac artery over the left common iliac vein. But this is misleading because a reduction in the diameter of this size often is not significant. Contrary to this patient, you see here on this video, the left interiliac vein has the same flow pattern. You see here the color like the artery. So the vein here should have been red and the artery blue, but the vein is blue. Why is that? Because the blood goes the wrong way in the vein. When you see a reverse flow on the interiliac vein, that indicates ipsilateral iliac vein obstruction. And you can see here with a Doppler, you see the Doppler, the artery going down this way, and the vein in the exact same way, and both have blue color. So with this, you can be certain that there is most often compression or obstruction of the ipsilateral iliac vein. And here is the example I showed you in the very beginning of my talk. This is the left common iliac vein compressed by the right common iliac artery over the 5th lumbar vertebra. And today, to speak the common language, it is better to use what we call topographic anatomy. We should avoid historical quotes and eponyms. This is not the McMurray, this is not the May-Turner or any other name. This is the iliac vein compression. That's it. And in this scenario, which is one of the 9 possible scenarios, the most common one, the right common iliac artery over the left common iliac vein, right, on top of the 5th lumbar vertebra, which is seen on the bottom here. And here on this particular patient, you see how the contralateral iliac vein is dilated and a huge flow. Look how the vein dwarfs the artery. Why? Because the right internal iliac artery, right, drains the blood for both the left and right lower extremity, because the patient has a severe obstruction on the left. So all the blood is diverted to the right common iliac vein through the internal. And that's why look how big the vein is. And here's some examples of compression when the classic one, the right common iliac artery compresses the left common iliac vein. And here is a significant velocity ratio of 5.8. But sometimes when the aortic bifurcation is a little bit lower, right, both arteries can compress the vein. See this little slit here? That's a vein, right? And more often than not, like over 90% of the time, with relative ease, you can put a glide wire here and go through this little slit and eventually put a stent. Now, I'd like to show you a nice study from Japan, which shows exactly that this obstruction is often synechia that connecting the adventitia of the anterior wall with the adventitia of the posterior wall, making like bridges, like you see on a bridge on a river. And you see these multiple channels. And this also made of collagen. The patient does not have to have thrombosis, and multiple studies have shown that this is the people are not born with it. It develops from the first and the second decade of life, and some people eventually become symptomatic, but we do not know the reasons. And here you see the staining for collagen, and see the entire thing stains as a collagen. And here you see one of our CAT scans in our recent paper showing how the vein, right, is compressed by the artery. And this is a different type of fenestrations of patterns of occlusion as described originally by McMurray in 1906 and subsequently by many others. And here's a venogram in one of our patients that shows that this thing, which is flattened, is actually the same vein. You see 1, 2, 3, 4, 5, 6 lumens. But all these lumens are the same vein that's been flattened. This white area here is actually the synechia that the dye cannot go through. So in a case like that, you need to put your wire in one of these lumens and eventually look at the vena cava, but not the collaterals, because otherwise you'll be doing the wrong treatment. And here is a patient with non-thrombotic compression. The vein has no clot, it's compressed by the artery, it's very high velocity at 2 meters per second. Be careful because people like to get a nice image and they put a lot of compression by the transducer, and this compression can be iatrogenic. You actually make it with a transducer. The prevalence of symptomatic non-thrombotic iliac vein compression is currently unknown. And here, I want to bring to your attention a phenomenon that has been described for quite some time now, that if the patient is examining the supine position, which is the most common position to examine the patient for iliac vein obstruction, the diameter here is 3 millimeters, 2.5 millimeters. If you start out the patient standing position, the diameter is 10 millimeters. This patient was presented live last year in the venous symposium in front of everybody. So you can see, when you see a non-thrombotic compression, you should examine the patient in the semi-erect or standing position, because many of these people alleviate or reduce the obstruction by just changing position. And I think it will be inappropriate putting stents in patients like that if have no really stenosis, only positional stenosis. And here you see with the color how nice and beautiful the vein is wide open. Sometimes what happens, the patient has stenosis for a long time, but this iliac vein stenosis, what we call is an innocent bystander. Nothing happens. This patient of ours underwent spine surgery, and after spine surgery, maybe of the surgery itself and the combination of the stenosis, developed femoral thrombosis. Even if the vein is thrombosed, you can see the stenosis because you can measure the lumen, which here is only 2.5 millimeters. Right? When the patient had, removal of the thrombus, the stenosis was relieved and it was unmasked and a stent was placed. But imagine, for how many years he had stenosis, nothing was wrong until he developed a thrombosis. And here is another example of chronic obstruction, and you see the remodeling of the vein. In the supine position, the iliac vein shows a larger diameter than the artery. If the diameter of the vein is smaller than the artery, even in the spine position, something is not right and needs to be investigated. This particular patient has chronic obstruction, the vein is only 7 millimeters, and with these huge collaterals, with non-phasic flow, bypassing the obstruction. Now, for deep vein disease, as Steve is going to tell you later, we perform, thrombolysis for thrombosis, stenting for stenosis and thrombosis. We have stent fracture, migration or malposition of the stent, and we use techniques such as ultrasound, axial imaging, phlebography, and IVUS. Steve is going to talk about the IVUS in a little bit. Here is an example of one of our patients that underwent stenting for thrombosis in the iliofemoral veins after thrombolysis. You see the stent is occluded. and both in the common iliac and the external iliac. You see now the floor of the common femoral is compromised, is non-phasic, is low augmentation, and the contralateral veins have beautiful flow with very good augmentation. So this patient, nothing went wrong, it's just patient's 80 antithrombin deficiency, which is very powerful thrombophilic factor. Now, other phenomena we can observe, the inferior epigastric vein that joins the great saphenous vein, and you see it often when you do ablation, right? The flow is from the abdomen to the groin, and the flow should be above the line and should be red. If the flow is blue and the flow is below the line, then you have diagnosed indirectly obstruction on the ipsilateral iliac vein. Actually, the vein is dilated here, is 6 millimeters, and look, on the other side is only 2 millimeters. So I repeat, this vein brings blood from the groin to the abdomen. If the blood goes from the abdomen to the groin, if it goes from the groin to the abdomen, that's the wrong way, so there's obstruction. Here is a patient with eastern stenosis. You see very nicely, the stent is white pattern on the bottom, but where the artery is crossing, right, the patient is a severe narrow is in here, and you see very nice, the color is the nice jet, and the compromised diameter is about 70% diameter of stenosis. So when you put the stent, it's not always successful. It might be technical errors, and Steve, who is going to tell us how to evaluate this and do, best placement. There's another patient where the stent was placed superbly, there's nothing wrong, but the patient had factor V mutation, which is, not, low importance factor for thrombophilia, but the patient stopped the articulation by himself and thrombosis his stent, as you see here. There is no technical error, but the patient stopped his articulation, and there is thrombosed iliac stent, as you see here. This is another patient now. With the ultrasound, we notice, you see this little area in here, right? Looks like an ultrasound artifact, but the interruption of the stent. You don't see the stent, the continuity. Actually, this patient has a fracture confirmed by the CAT scan, as you see here. Stent fractures are not very common, and in the veins, they seem to be a bit more benign when compared to arteries. There's another patient that has, here, poor dilatation of the stent. You see the stent here. The stent is going to be very wide. You see the artery here. It's going to be at least as wide as the artery, but it's not. And it's obviously thrombosed because the patient poor dilatation of his stent. And here on magnified view, you see how the lumen is narrow, and you see the thrombosis of the stent. Here is another patient on the follow-up where it was done 5 years earlier successfully. But as you notice, the original stent was 14 millimeters, but even in the area it was all compressed. This is a wall stent here, by the way, is smaller. But under the area of the compression, the stent has not fully opened, is 9, and a bit further up is 7 or 8 millimeters. However, we did nothing with this patient because 5 years later, this patient is asymptomatic, is extrinsic compression with no intraluminal growth or thrombosis. Now, this is a female patient, which is 43 years old, after thrombolysis. This was the days where the wall stent was extremely oversized because the times is go big or go home. And you see what happens when the stent is so big, it can cause stretching of the vein distally and cause tapering and stenosis. And here is another technical issue that can be easily identified by ultrasound. The stent was terminated at the distal common iliac vein. That's a very bad area to land the stent, because the diameter is very big here, you have the mouth of the entire iliac. Therefore, you cannot achieve wall position. And you see here, it's a poor wall position, the stent is floating, and there is blood around, and the posterior wall is actually thrombus. So now most people avoid to put the stent in here, they go a bit more distally, and that's why actually we need IVUS, and Steve is going to tell us its importance in a little bit. Here you have another scenario where 2 stents were placed, and the stents were oversized, and look, the stent is protruding on the wall of the vena cava, causing severe tapering on the top. You see the 2 stents in here, right? And look how much bigger they are, because ideally you should be stents which are, up to 14 millimeters. If you start with 16 or 18 millimeter stents in the vena cava, this is what's going to happen. The lumen is going to get too big, and you're going to cause severe stretching and stenosis above the vena cava, above the stenting. And here is thrombus layering. You see very nicely over time. Thrombus can be on the stent, and eventually this can lead to occlusion. See the magnifying view very nicely. And this phenomenon can easily identify by ultrasound. There's a nice paper by Barbati et al. That so that actually, to summarize, stent, the ultrasound is a very nice way to follow up people with stents. And there's another paper from Switzerland that I recently reviewed for the European Journal of Vascular Surgery. It's been accepted for publication. Actually, it's been in press that shows also that ultrasound is a very good way to follow up people with venous interventions. Now, key points for this lecture. Non-thrombotic iliac vein obstruction is fairly common and often asymptomatic. It is not congenital in the vast majority of people and develops over time, starting in the second decade of life. Many patients develop symptoms after a thrombotic event ipsilateral to this obstruction. It is not clear why non-thrombotic obstruction leads to symptoms by itself. Many patients develop signs and symptoms of iliac vein obstruction alone or in combination with other pathology factors. Further studies are needed to understand the importance of iliac vein obstruction and how intervention impacts clinical outcomes. Guidelines for follow-up after endovenous procedures have not been established. Follow-up consists of clinical exam and objective imaging. Most practitioners parallel the arterial serial follow-up. Ongoing future studies will demonstrate what is needed for endovenous procedures. Thank you very much, and I hope we can discuss a few things later. Thank you, Sergio. Sergio, unmute yourself.
Okay, can you hear me?
Yep.
Okay, thank you so much, Nikos. And I'm now sharing my screen because we are moving to the scientific world around. It's a pleasure for me to see that we had more than 600 people listening to you on Zoom, plus all the other ones, Nikos, on Facebook, because everybody should enjoy your talk around the world. And I also think that everybody should enjoy the Venus Symposium activities you are doing to teach so nicely about ultrasound and many other things. So as you know, now we are going to have 10 minutes dedicated to top experts that are representing the different continents. So I will allow now Willie, Professor Chi, to introduce the first one, and then we will move through all the continents. So Willie?
Yeah, our first panelist is a well-known venous ultrasound expert from IVUS, Marissa Ho. Marissa, you want to go ahead and start?
Yes, thank you so much, Dr. Lapopoulos. That was an amazing presentation. So one of my questions is, I know there are no clear guidelines as far as following up endovenous procedures, but do you have recommendations on what we could be doing? And also, I have a question of, have you ever seen any kind of sonographic characteristics that may help predict which patients are going to develop deep vein thrombosis versus which patients may not with iliac vein compression syndrome?
Very good. So for the follow-up, I'll tell you what we do in our institution currently. When a stent is being placed, we see the patient within the first month, and then we see at 3 months, 6 months, 1 year, and a year thereafter. And some data going around that if the stent is open in the first year, nothing happens after, but really I have not something robust thing being published. So currently we do, as I told you, within the first month, 3 months, 6 months, 1 year, and a year thereafter. Then, for your second question, if there's any predictors for rethrombosis, when you have the compression, you have iliac vein compression, you didn't get the, what was the reason to predict thrombosis when a procedure has been done already? Or in general, if there is a compression?
Just more, do you find that the patients who do develop thrombosis, are there any differences in their ultrasounds that you have noticed as far as maybe a specific velocity? Patients who have a certain, stenosis are more likely to develop a thrombosis?
Well, people generally have lower lower inflow, and it's very clear now, we know from multiple studies, if a poor inflow, and I'm sure Steve Black and Dr. Wick can tell you that they have a higher failure rate. That's the obvious reason we know regarding the inflow or the flow characteristics. People that have, early in thrombosis, the lining I showed you on the last slides, right? If they develop this inner lining, the layering of thrombus, they're more likely to occlude later. But we don't have to look at robust criteria who's gonna get into trouble looking at the flow only. There are other characteristics, of course, if the stent is not placed properly, right? Like I saw, the slides, a patient, instant stenosis. A patient like that most likely is gonna develop failure later. Or actually, this patient was symptomatic before even developed thrombosis. But we don't know, some people, the thrombosis, as I saw you, nothing wrong technically, the flow was perfect, but the patient interrupts prematurely his anticoagulation. Or sometimes people having very powerful thrombophilia, like the dithrombin 3, and thrombose despite being anticoagulated. So it's not always easy to predict. We can tell it in some people, but not on everybody.
Well, wonderful discussion. Now we move on the way to Asia with NG Jia from the Harley Street Heart and Vascular Group of Sriram Narayan. She's a top expert in ultrasound. So NG, can you make your question to Professor Labropoulos? NG?
Yeah.
Great.
Thank you, Dr. Labropoulos, for your sharing. So I noticed that you use luminal diameter as your diagnostic criteria. So there are many occurrences where there's asymmetrical compression, where there's reduction in diameter in one plane, but that doesn't necessarily reduce the entire luminal area. So would you reckon the area reduction ratio will be a more reliable assessment of stenosis?
Yes, you can use the area reduction as well, but I think that more accurate when you use the IVUS itself, because the ultrasound will be misleading because of the angle. If you, for example, cut the vein as it dives down in an oblique fashion, it's very easy to make a big mistake on the area reduction. You have to be very aware of how you're making the measurement. And perpendicular axis on this vein is not always easy in the iliac veins, particularly as they dive down and then climb up again. So it's possible. It's not been validated. Some work done by Dr. Razu, but I think it needs to be tested further. Currently, I think it's not for a prime time for area as measured by the regular ultrasound, currently. Okay. What we're doing now, I have not said anything. I didn't say it because I have not published anything of this. We measure what we call the short axis of the iliac vein and find what is the minimal diameter that would predict with 95% positive predictive value severe stenosis. We know the data. We've done also extreme mathematical modeling. We examine all possible scenarios and we have the answers. But I won't say anything until we present this in a meeting or publish, because it will be premature now.
Okay, thank you so much. Now we move to Europe. Oscar, are you ready to introduce the representative from Europe?
Now, yes. Now let me introduce a top expert in venous and lymphatic from Italy, Maurizio Pagano. Go ahead.
Maurizio,
se
vuoi fare la tua domanda? Maurizio?
Congratulations for the outstanding lecture. Is anything? Okay.
Yes. Sì, vai.
Pronto?
Sì, sì,
okay.
vai.
Congratulations for outstanding lecture. Do you have any tips for defining a proper inflow in the internal and external femoral vein in case of common femoral standing planing?
Yes. I said in my lecture, we always examine with the ultrasound the femoral veins because we need a good inflow. Typically, most of the time, the deep femoral vein is open and provides adequate inflow. However, we don't have limits or criteria defined by the ultrasound or any other method of what is truly an adequate inflow. And we discussed it with many colleagues of how can we, with what kind of method can we predict this? Probably Steve may comment on this later as well, or Keith has certain experience, or Mark Garcia there, he has certain experience with this as well, or Igor Sicos from Brazil. But as I said, I don't know of any criteria currently. It's mostly experience than science.
That is great. Thank you, Nikos. And now we finish the word round all the way in Argentina. Willie, would you like to introduce the expert discussant?
Yeah, it's my pleasure to introduce Dr. Jorge Segura, one of the best ultrasound experts from Latin America, to give us the last question for Nikos.
Congratulations, Nikos, for your excellent exposition. How long do you consider necessary for adequate training and experience to perform vascular ultrasound exams? And what do you think of the Raju test to measure different venous pressure, arm, foot, and increase venous pressure of the foot with reactive hyperemia for the evaluation of the degree of obstruction in patients with chronic venous disease?
That's Jorge, thank you very much for your questions. Nice to see you. These are excellent questions. For the ultrasound, it depends on the background of the person. Who is the person who is letting the ultrasound? And are we talking about only venous ultrasound? Talking about only iliac ultrasound, pelvic, abdominal? People certainly have experience in examining the lower extremity. It's easier to learn the pelvic ultrasound because of the skills to examine the human body, right? But I would assume if the patient has the specialist has already knowledge of ultrasound in other areas, it will take probably 3 months to master, you know, the abdominal iliac veins very well. And of course, you don't learn everything in 3 months. You learn all your life, right? It takes more time. I guess if you get a year under your belt doing these exams, then you become really, really confident. But if you have no idea whatsoever, then it will take exactly the time to learn the ultrasound first. And on top of that, you have to add the time for the abdominal pelvic veins. And here we discuss, as you saw, only the obstruction of the iliac vein, but you need to understand the anatomy issues with the vena cava, right? Then if you have a reflux because of the pelvic regions, like in the pelvic vein disorders, you have compression of the left renal vein, and then extrinsic compression by masses, cysts, and other, you know, it's a lot of things to put your differential diagnosis. So definitely this requires a lot more time. But just to perform the exam with some, you know, accuracy and feel good that you've done like a decent job, I think if you know already ultrasound, at least 3 months necessary to master that. I mean, I'm probably, Diana can comment on this as well.
Okay, thank you, Nikos. You know, I'm the bad cop usually.
Oh, the arm-foot pressure differential. I happened to do a study that was published in 1997, but this is a pretty aggressive study to do, you know, to put catheters in the arm and in the foot and do at rest and exercise. It's a very good test, basically, if you do it properly, right? But the thing is, and I think Kees can tell you because they've done some beautiful studies in Holland with the patient actually on the standing position. Nothing beats the patient being standing and walking. And I think, in my opinion, the physiological position to test anything in human body is when you have physical activity. Unfortunately, all the studies we're performing currently are with the patient supine, CAT scan, MRI, ultrasound, venography. And this is inappropriate because you study basically morphology, no function. You look at the function a bit indirectly, but does not represent what happens to the patient when he walks. And as you know, Jorge, the people have symptoms when they stand or they walk, not when they are in bed. And that's why I like the work they've done in Holland with the patient actually studying or being on treadmill.
Okay, I have to stop Nicopedia because if not, we stay here for many hours. So Nikos, thank you so much for that. Now we are like running a little late on time, so I will welcome one question from the audience, and we always go with the ones that gets more like, so that is representing more the audience. And in this case is coming all the way from Egypt, from Wasila Taha, the Cleopatra of ultrasound. And she's asking, there is a lack of training for pelvic vein scanning. Most of the non-invasive vascular labs starts at the inguinal region. Interrogating the femoral veins, how reliable is the loss of the respiratory phasicity on these veins? could be sensitive enough to indicate that there is an ipsilateral significant obstructive lesion? This one is the question who got more likes. All the other ones will be replied by Nikos in the next days, so don't worry. Nikos?
You want me to answer? Or?
Yes, answer to this one, and the other ones will be...
The like for respiratory phasicity is very important because it indicates obstruction. That's for sure. The thing is, as I said earlier, this does not give you license to treat the patient. The patient has appropriate symptoms, and you do the right procedure for the right symptoms. So finding an obstruction is just the beginning. And the lack of respiratory phasicity is one of the most important indirect signs for addressing obstruction. But if you find this, then with the ultrasound itself, or if you're not possible to do this, either with CTV, IVUS, or venogram, you have objectively find what is the extension, location, and severity of the obstruction. And then if you put this together with the patient symptoms, then you can address that with any treatment you want. And I'm sure Steve will talk about it later.
Sure. And during the open discussion of Steve, we'll also have the chance to go back to Nikos in case we have time for that. If not, he will reply, I'm sure, during the week. So now let's move forward. I will share my screen once again. And let me get to the point. I have, again, the issue of presenting somebody so big that would be like a sting, since in particular we are from UK in this case with Stephen Black from Guy's and St. Thomas NHS Foundation Trust. He is really well known from all these publications, and I have to say that I've never heard any single complaint about him from all around the world. So he must be really a really nice person. So Steve, if you can share your screen and get started with your presentation that will be dedicated to IVUS and again, the evaluation of the iliofemoral venous obstruction.
Hello, everyone, and thank you, Sergio. You can tell that it's been locked down for 3 months because my hair is a lot longer in this picture than it is on the one you showed before. And that's a reflection of no hairdressers being open. Nikos has given his usual superb introduction to this, and it's always tricky following on from Nikos because you feel inadequate in your knowledge once you've listened to him for 15 minutes. But IVUS, as Nikos showed in his one slide, is a component of evaluation of venous disease. And I think the problem for us, and many of the questions that I've been watching on the chat have shown this, is that we really lack a diagnostic equivalent of something as simple as ABPI in arteries to help us understand when there's adequate flow, inadequate flow, or whether patients should benefit from treatment. And all the studies on flow and pressures and so on are quite cumbersome to perform and quite difficult to bring into your own practice because they're not, because they're not straightforward. So principally in venous disease, we rely on diagnostic imaging studies to allow us to select which patients to treat. And not one single study we have gives us all the information that we need. So it becomes a sum total of all the bits of information you get from really good duplex scanning, like Nikos has shown, MRI scans, CT scans, and of course, as far as I'm concerned, IVUS is an essential component of that. So IVUS investigation, as we can see from this image, really starts with anatomy. You need to know where you're seeing the vessel crossing, where you're seeing the branches, adjacent structures, looking for trabeculations in the lumen, identifying normal vessel like this distal common iliac vein, which is overdilated from the external iliac vein, which is normal, and being very clear on where you're seeing the different anatomical areas that tell you what to treat. And the problem with IVUS to some extent is if you're familiar with duplex scanning, you'll understand the imaging, but if you're not familiar with duplex scanning, it takes a bit of time to get used to it. And it's further complicated by the fact that IVUS is with the Phillips catheter and others are spinning. So the anatomical orientation is unusual for most people, and you have to get used to trying to put the image in the correct plane in your head and where you see the bits and pieces that cross. What we know from IVUS is that it adds significantly to the diagnostic pathway. Paul Gagné and colleagues did the video study, and while there are obviously criticisms of that study where it was non-randomized, for example, and there's a lot of subjective interpretation of imaging. What it did help us do is move a little bit further along the line of gaining evidence for IVUS, which is still considerably lacking in the literature. But it did demonstrate that IVUS improves diagnostic sensitivity over venography alone when you're looking for iliac outflow obstruction. It did improve the detection of causative lesions in where you found something that otherwise would. But undoubtedly questions still remain that need to be answered by further studies. IVUS helps you to identify a stenotic lesion, and one of the criticisms of IVUS is that it's obviously prone to subjectivity. If you draw these diagrams, these lines on a lesion, you can make it slightly smaller, slightly bigger, depending on what you want to do. And that's part of the problem with IVUS, but obviously there are many things in medicine that lend themselves to people doing things that are wrong if they want to. So if we assume that people are trying to measure as accurately as possible, you do get a very good idea of area and dimension changes that allow you to determine whether a lesion meets a threshold for intervention. Video has suggested that we should set the threshold for intervention higher at 60% for iliac vein outflow obstruction, where there is no thrombotic component, rather than 50%. And we do need to remember that a lot of these numbers are not evidence-based. 50% comes from a random number in the literature that has become gold standard. It's very easy to see if something's completely occluded in IVUS, and one of the things that IVUS does show you is why you're able to cross lesions. You can see in this picture here, this is a chronically occluded vessel, but there are some little holes that you spot outside of the tissue, and these are those little flow channels that Nikos was showing in his previous discussion, and it's that your wire gets through. And this is what tells you why, if you see big loops when you're trying to cross a chronically occluded lesion in iliac vein disease, you're not inside the vessel, because there's no way that a wire can form a big loop in tiny little channels like that when you're crossing chronic occlusions. It helps you identify a good area of landing for landing zone of the stent. And I often find that when I'm consenting patients who might have an endophobectomy fistula, for example, I can only really make the decision for that on the day of treatment when I put IVUS in, because you often see a landing zone for a stent that may not have been apparent on any of the preoperative imaging that allows you to get away with a full endovascular procedure rather than have to commit to endophobectomy and fistula, which is a very morbid operation. IVUS is very useful in helping you decide the landing zone. I think that the tendency, if you rely on venography alone, is to land your stent short. So you might end up sitting here because that looks okay. But once you use IVUS in combination with bony landmarks, and Jerry O'Sullivan published a very nice paper about the reliability of bony landmarks last year. If you use IVUS in combination, you'll tend to find that your stent is placed higher than you would otherwise have thought. And I've frequently seen that in cases where the vessel crossing on the left-hand side is not always the same. So the vessel can cross steeply like this. It can be oblique and coming across like that. It can be slightly lower. It's not completely consistent. And without IVUS, I think it's very easy to miss the landing zone. And one of the biggest causes of stent failure is landing your stent short, and then the artery rolls over the end of the stent and you get a recurrence of the outflow obstruction, which can compromise your original procedure. The IVUS catheter is very helpful with measuring markers, which are useful for two reasons. One is to work out how long your stents need to be, and the second is to work out where your stent overlap is going to be placed. I think it's increasingly important to recognize that stent overlap is a crucial area. It changes how the stents behave, and you want to minimize the number of overlaps. You don't want to have a stent overlap at the bottom of the pelvis here, and you certainly don't want to have an overlap underneath the inguinal ligament here. So you want to try and overlap your stents in the external iliac vein, which is a relatively stable position. And therefore, using these centimeter markers, you can work out how many stents you need, what length they need to be, and make sure you get the position right rather than just stacking your stents from top to bottom. You use the tip of the IVUS catheter, you can see coming back here, will tell you where the distal landing zone is. And this gives me a length of the lesion, 24 centimeters in IVUS, and I want to overlap my stents somewhere up here in the external iliac vein so I can choose the right stent size. In addition to length, we want to get the diameter of stents right. And I think diameter in chronic disease, where there's an occlusion, is not really an issue. You're going to dilate the vessel up to the size of stent you want, and I typically use a 14 for the majority of those patients. But in nivel lesions, it's very important to get the sizing and position right, because the biggest problem we face is stent migration and embolization to the heart, which is a disaster. That's a lot to do with stent sizing. So I will take a minimum and maximum diameter. You can see here, if we take that where we have measures of 4, I take a halfway point between those two measurements and oversize by 2. So halfway is 11.8, I'll end up with a 14 stent. And the same thing applies here in the normal common femoral vein. It's 7.6 and 13.6. Again, you end up with roughly a 14 stent. So most of the time for me, with these sort of measurements, I end up using 14s. I hardly ever go bigger than that under the ligament in particular, because I think you get pain. The bigger you go with the stents, the more likely you are to get back pain. So getting the sizing right is very important. What you want to do is stent and get the vessel crossing right. You'll see from this loop picture here, we're looking for the artery that comes across there. You don't want to be short of that artery, so you want your stent to start landing in the vessel crossing. And if I take that back coming through the artery, I want my stent to be sitting about there. And that will correspond to the tip of the IVUS catheter here. And in most patients, if you rotate the image properly, that sits just to the left of the spinous process on the left-hand side. And that's a very reliable landmark to look out for when you're looking for the central placement of your stent. This is the IVUS catheter that shows you where you place the stent. You've got that sitting on the spinous process where we measured, and that allows us to place the stent accurately. The distal landing is the same thing. We're looking for the profunda takeoff to make sure that we land the stent on the confluence of the profunda as tightly as we can. So we saw there the GSV origin was coming off, and now we're going to see that we're going to come up to the profunda origin, which is taking off just over there. As I come back through that, I can see the profunda is disappearing over here, and that's where I want the bottom end of my stent to be, and that is very often right by the lesser trochanter. So that's another good landmark to look out for when you're looking for IVUS. You can see here that we do not want to have a stent overlap around the femoral head. So if we're measuring our stent to end up with a stent that stops over here, you don't want to do that. So these overlap zones are really, really bad, and you want to put your stent overlap higher up. So 9 centimeter stent would give us a bad overlap just on the ligament. We want to go higher than that. And this allows us post-op to check the end of the stent. You can see the profunda vein is there. And as we come up from it, we've landed exactly on the profunda. And it's that sort of accuracy of placements. I think the landing on the profunda is the same as the renal arteries in endovascular aneurysm repair. You want to be as crucially on that as you can and avoid any disease that's left behind. And you can see here we do IVUS post the stent. The vessel crossing is now widely open in this particular patient. The stent is good and round and well open. There's no compression points. And this means that we can check that there's no problems. Occasionally in IVUS, I've seen a thrombus within the stent at the end, which tells me that I haven't got my anticoagulation right. You're looking for your landing zones to make sure that they're absolutely spot on and perfect. And these are difficult things to pick up on venograms, and you can do spiral CTs, but that's a lot of radiation that the patient's going to get. One of the most crucial areas that I find IVUS to be useful is reintervention. Nikos mentioned it, and we can see where you get problems in stents and you may require reintervention. You can see in these two patients that both come back with in-stent stenosis. This patient, you can see that the flow lumen is less than the stent, and there's a collateral here. But both these images look very, very similar. And it's difficult from just the venogram to work out why there's a problem. So if we consider the patient on the left, as we come up, we can see the profunda comes in, so the landing zone is good. You can see thrombus within the stent. As we go all the way up here, the stent lumen stays nice and round the entire way up. So in this particular patient, this was an inflow problem that was related to the quality of the inflow vessels. It wasn't a technical problem, and we had to work on improving inflow. In the patient on the right-hand side, where the venograms look similar, if you watch the stents at this point here, they suddenly collapse down, and then you see the stent open up again. So if I go back through that, you see that stent almost disappears completely. And this corresponded to the inguinal ligaments in the femoral head, and this is a common point of compression in the stent. It actually fractured here, and this patient had developed further in-stent stenosis. So this patient, the venogram looks similar. but it's a completely different problem. And in that patient, we had to, I cut the inguinal ligament and I relined the stent with a wall stent to support that pointed compression. So the summary then for this is, I think that IVUS adds significant diagnostic value in the patient workup and pathway. It reduces radiation for patients in treatment. It reduces contrast dose. It's completely repeatable. And it certainly improves the sensitivity of diagnostic testing. The debate is whether that's overly sensitive or not. That's the question we have to answer. But it's an essential part of a complete venous service. And if you don't have good imaging in all stages of treating venous patients, you're going to make mistakes. But I think we certainly need proper data and evidence to support its use and demonstrably show cost effectiveness and improvement in outcomes, which is still lacking for IVUS. Thank you very much.
And thank you so much, Steve. And as a revenge for your comment on hair, I will simply say just have a look not just with the hairdresser, but also with the Wi-Fi technicians. You maybe need some help for that. And talking about hair support, I'm going to introduce the other hair mate I have, so Domenico Bacciglieri from Europe as Continental Top Experts representative. And jokes aside, is for sure somebody we will listen to a lot in the future because he's extremely talented and he has a question for you. Domenico?
So thank you, Sergio. I would like to say thank you again to the BWIN Foundation and also to Willie and Oscar. And it's a great honor for me today to represent Europe. And thank you, Steve, for your outstanding contribution on IVUS. You know, I started my venous program without using it, and then I discovered a new word. So today my question can be a little provocative because I think that IVUS may be mandatory in acute cases and post-thrombotic cases. But regarding a standard May-Turner syndrome procedure, if you have a CTV or MRV, do you think we can avoid the use of IVUS or is it mandatory for diagnostic reasons?
That's a very good question, Domenico. And I think the answer is there is absolutely no evidence to say whether something should be mandatory or not. And the view comes from an opinion that is driven by adding value in patients. And I think in the non-thrombotic iliac vein lesions, there are a number of clues you're going to go on to decide whether to treat a patient. For me, in those settings, it's not so much that IVUS will tell me there's a compression. It may add some value to the compression being more than I've seen on MRV or more than I've seen on duplex. Bearing in mind that all these studies are done with the patient supine, so we have to bear that in mind. But I think when I styles the stents and position stents, I find IVUS very, very helpful to make sure I've got it in the right place. And I just find that if I'm going to treat somebody who is with a nibble, I might not even use radiation or contrast at all and treat them. And these are young patients with pelvic vein issues. And I think the added benefit of no radiation and no contrast are things that matter to me. So in my opinion, I still use it on all patients. Can I say it's mandatory? Of course not. You know, there's no data to back that statement up, and then it just becomes an opinion that is very forcefully held.
Okay, thank you so much, Steve. Now we move forward and we introduce from North America somebody who needs no introduction. Oscar, are you ready to introduce the expert?
Yes, it's my pleasure to introduce a world-renowned expert on the topic, Professor Mark Garcia. It's a pleasure to see again, Mark.
Mark? Unmute yourself.
Yep. Can you hear me?
Yep.
Yes.
Okay, great. Thank you, Oscar and Sergio and Willie. Great show again this week. Stephen, fantastic presentation. My one comment to the last question will be that I think we all see patients that have May-Thurner when you do venography, that it actually doesn't look so bad. And you put IVUS in and it looks really, really tight. So I do think that we have to come as a society and really look at this in depth and come with some recommendations. I think we miss we miss a lot of lesions that otherwise would have been left alone when patients have significant disease. But my question to you, Dr. Raju and his colleagues have done tremendous work in leading us to better understand the significance of iliac vein compression. He reports his quote unquote normal size in the veins as 200 millimeters square, 16 millimeter diameter in the common iliac, 175 squared in the external iliac, and so on. A lot of questions come up as to whether or not we believe that these are the numbers that all humans, we should be following for all humans when we treat. There was a study, a paper by Randy Hoffman and colleagues who reported on over 3,500 asymptomatic patients presenting to the ER at Stanford, where they looked at multiplanar imaging. And they actually found that the average size of the common iliac vein was about 12 millimeters and the external was about 11 millimeters. When you take into effect if you take the example of a compression of a very compliant vein as demonstrated by a water balloon, as you compress it, one side expands while the other is being compressed. And we all see that on IVUS. However, many people say when they're looking at stenting, they see and measure that there's 20 millimeters in the longest length and maybe 7 or so in the short length that's being compressed. And so they'll use wall stents that are 20 millimeters, which I think is the wrong thing to do. I'd like to get your impression on that. And how do we best accurately measure that diameter? I know you used your example here, but can you expand on that for the present? Because I think what we get into is people oversizing stenting, and it causes compression of the contralateral side and actually thrombosis on the contralateral side by using large stents that extend up into the IVC. So can you please comment?
Yeah, Mark, I mean, that's a really good question, and there's probably a whole essay to be written to answer that in all its facets. I think if we take the first thing first, what is the normal diameter of a vein? You know, Raju did a lot of work on it, and the 200, 175, 150 measurements he came up with correspond with 16, 14, and 12 as a diameter for stents across the board, which is why, you know, Raju was involved in designing the Vici stent, and that's why they came up with that size range to fit with those numbers. I think the problem, and ironically, it's also driven by Raju that has crept into it, is the stent dynamics have affected what people do to size them, and they haven't taken into account what the stents actually do. So a 16 millimeter nitinol stent placed into a vessel will not be 16 because it has to be working, and for it to be working, it's got to be reduced in size. So the actual diameters we get are smaller than we think when we place stents in to start off with. And the wall stent sizing is really driven a lot by the fact that what Raju was trying to do with an 18 or 20 wall stent is increase the length by dilating it to 16, so he could get 120 length out to reduce the number of wall stents he used. Plus, he was giving himself the option of going back later when there was in-stent stenosis to over-dilate that stent, which is a factor of wall stents. And those are not features you get from nitinol stents. So the first thing is the technical aspects of choosing stent sizes are not related to the size of vein we're trying to treat. They're slightly separate. And I think actually in chronic disease, if you get somebody to 14, they're going to be fine. My criticism of Randy Hoffman's work from Stanford, which is a great series of patients, is obviously nobody's presenting to the ER and having cross-sectional imaging for no reason. So those patients are going to be immobile, dehydrated, have been sat around in an ER for a period of time. And Case has done a lot of good work on size measures and dynamics of veins, where he's demonstrably shown that if you exercise or you hydrated or whatever, the size of your vein will change. So the timing of where you measure veins and what the patient has had beforehand is different. So these are not normal people who worked in off the street. They were presenting to the ER at Stanford. So they were not clearly, physically running around actively healthy people. So I think we've got to bear that in mind when we look at it. But either way, we're in a range of 12 to 16 millimeters for a common iliac vein, or 13 to 14 for the external. In my practice for those measurements, I normally try and measure off the normal external iliac vein. It is a mistake to measure the pre-stenotic dilated area of the common iliac vein, and that is why people end up putting in big stents. If you do it with wall stent, it may be all right because the wall stent never gets out to 20. It ends up being 16 or 14 or getting smaller. If you put in 20 nitinol stents, you will have big problems for those patients because they get back pain, the stents straighten, there's all sorts of things that will come off that. And over the years, as I've been placing nitinol stents, we've probably moved back down towards 14 from 16s, and that's the workhorse size. So I think there's a lot of education that we need to put into place to people how to measure. There's misinterpretation of Raju's data. There's overstating of the size of veins. I don't think we need to be too big. We need to be big enough to relieve symptoms, and that's what you're trying to. So that's a short answer to a very good question.
Okay, thank you so much, Steve. Now we fly all the way from North to South America. Willie, could you introduce the next top expert?
Yeah, it's my pleasure to introduce Dr. Igor Stinkos, our Latin America panelist from Brazil.
Igor, the mic is yours.
Hello, everybody. First of all, congratulations, Sergio and Oscar, for this incredible project. And congratulations to Nikos and Stefan for this outstanding lecture, the speeches. It was really, really good for us. So in South America, we have IVUS available for more than 10 years, but mostly services that have this tool are related to São Paulo area and very few in the rest of the country. So I believe the lack of IVUS technology limits not only the specific case, but help us to learn and understand endovenous treatment. So I think IVUS is a tool that is part of the process of learning. And my question to Stefan is how he deal with missing border is a practical question. When you have different angulation of cava and iliac veins and the wire is not central on the vein, in this case, we can go in and out. We are certain that we have an obstruction, but it's difficult to determine all the veins walls in the same picture and to draw the stenotic lesion. How do you manage that? How do you deal with that to decide what to do?
You know, that's a very good technical question, and I think that's why I don't use one thing to make a decision. So if I put IVUS in and I don't see anything and I'm not sure, it's not that IVUS is a yes or no, true or false binary decision-making thing. In chronic obstructive disease, you're never in any doubt. Everybody knows that that's easy. If you see webs and trabeculations, that's easy as well because you know that there's a problem. So the patients we really have a difficulty making decision in are the patients who have a non-thrombotic iliac vein lesion without obvious webs or trabeculations where you're not sure whether a stenosis is truly significant or not. And in those patients, what I found useful to do is I take the IVUS out and I inflate a 14 or a 16 balloon to about 1 or 2 millimeters of atmospheres, so it's not high pressure, and then I pull that balloon down to the common femoral vein. Normal veins will expand to accommodate that balloon, and if the balloon comes down without any resistance, there is nothing significant there in my opinion. If you have a genuine lesion, it will catch the balloon and you will feel resistance, and sometimes that's helpful for what Raju described as a Rokitansky stenosis, where the vein wall has become fibrotic, but there's no intraluminal damage, and the vessel has just lost its ability to expand or contract. And then you will find that a 14 balloon will resist as you come down into the external iliac vein or through some of the compression points. And that's an added thing where I'm not sure, and the IVUS isn't clear, and I'm weighing up whether a patient should truly have a stent or not is what I tend to do to answer that question.
Thank you so much, Steve. Now we'll fly all the way to Asia. It's my true pleasure to welcome Tarun Grover at the mic. He's one of really the top experts. Whoever enjoyed his talks from the stage knows like it's really worth it to listen to him talking. So Tarun, it's yours.
Yeah, hi Steve. One quick question, Steve. You know, we occasionally see these patients who have chronic obstructive disease extending into the IVC and coming from both the iliacs. So either we placed one large stent in the IVC and 2 stents telescoping into that large stent, or sometimes we end up using 2 long stents. So are there any specific IVUS findings to take this call, whether we should put 1 large stent in IVC and then 2 stents telescoping into the common iliacs and bringing down them to the external wherever the healthy segment is, or just 1? So is there any specific IVUS finding to choose from these 2 options?
Turin, I think what IVUS does is tell me what the extent of the disease is. And my decision on using a large stent in the IVC, a single large stent and double barreling 2 stents into that, or restricting to just 2 double barrel stents, is really about where the top end of those stents are going to be. I tend to find that if the vein is coming, the IVC comes back normal in only really 2 places. It either starts being normal at the renal veins or it starts being normal at the hepatic
veins. The hepatic veins.
So if I have to just go to the renal veins and everything above that is normal on IVUS, I will tend to just double barrel stents. That's fine. You don't need another big stent, mainly because the anatomy of the angulation from the left, if you try and make a stent turn into a big stent below the renal veins, you get problems with those stents. If I have to go to the level of the hepatic vein, then I tend to put a big stent above that. So the decision is more about the level of stenting rather than the IVUS findings, because IVUS is telling me where I have to go to. Is it normal at the renal veins or is it normal at the hepatic veins? That's what I'm getting from IVUS.
Okay.
Thank you so much, Steve. Now, before moving to the final part, we will welcome, of course, from the audience the questions. The best one is in terms of how many likes I got from Dennis Borsuk. Is writing, the question is for both speakers. Have you ever thought that stenosis of the iliac vein in patients with iliofemoral thrombosis can be secondary to lack of the flow? So if thrombus completely recanalized, the stenosis would disappear. Do you have some experience of such follow-up? Again, this is open question to you and Nikos, and if Dennis wants to clarify better what he means, he can open up the mic.
No, I mean, Dennis is very experienced, isn't he? And he's, thank you for the question, Dennis, of course, and nice to virtually chat to you. I take what he means by that question is if you have thrombosis in a vessel and you reduce flow, that vessel caliber is going to get smaller. And that's, of course, has to be the case because veins are capacitance vessels. And if there's thrombus and blockage in a vessel, you're going to make it look smaller. So I would never measure stents to size them on a vessel that's completely obstructed based on those things. You want flow. And if you have no flow, you're not going to be putting a stent in anyway because then it's going to block. So I'm sure that flow affects vessel diameter, and Nikos, of course, will give a much better answer than me. So I'll let him go now.
Nikos?
Steve, yeah, I think what happening here is on the veins, we don't see the same phenomenon like in the arteries. This phenomenon is known as adaptive low flow remodeling for the vessel because due to lower shear stress, decreased diameter, but on the vein it does not happen for the following reasons. If a femoral vein obstruction, you still have a good inflow from the ipsilateral interiliac vein, and the iliac vein remains open. We have not published this, but we have studied this carefully, that the significant reduction on the iliac vein does not occur with femoral vein obstruction. It doesn't.
Okay, Nikos, so we stay with you since now we are moving to the take-home messages with the honorary chair. So you, Diane Newhart and Chase Wittens. Of course, all the questions will be answered. I'm sure that Steve and Nikos are so nice that they will reply in a written form and you will find the answers in the website. So Nikos, can you give us your insight of what we should take home as messages after this webinar?
I believe that we have entered a new era where endovascular treatment is feasible and the main way of addressing people with chronic obstruction in the iliac veins. Therefore, rigorous training is necessary for imaging the patients properly, but also providing the studies that support which patient should be treated when and by which method. And I think we require multiple experts together to put our heads to resolve issues. I know, for example, Steve is working now on a big ulcer project regarding stenosis and how this should be addressed. But definitely, although we're moving towards the right direction, we have many things to learn because this is a relatively new territory. But I like to say something that's very important. In medicine, when something new happens, then you have disease that obviously is recognized more often, but ironically is overtreated and undertreated. undertreated because people don't recognize it, and overtreated because people treat many patients who don't have any issue. They have like an innocent bystander, a stenosis that it causes no problem. And to tell you one issue which I opposed Raju face to face, no problem, when he invited me to his place, is from the get-go, I do not believe that a 50% area reduction by itself is a significant factor to cause stenosis in the vast majority of the patients. And I stay there.
Okay, thank you, Nikos. Now we stay in North America with someone that is for sure a queen of the ultrasound. So Diane Newhart, can give us your take-home messages from this webinar, please?
Well, thank you everyone for attending. I also truly enjoyed both of the presentations. Of course, Nicopedia is obviously fantastic. And Stephen, I really enjoyed your presentation. Within our center, we're doing extensive IVUS, and I loved your take-home message because I think it's true. I think ultrasound is extremely sensitive and specific, but sometimes doesn't correlate with maybe less sensitive imaging. And IVUS in our center has really expanded our ability to rely on our ultrasound in a way that we can move forward. So I appreciate both of them. And one of the things that struck me about Nikos's presentation, and I think it's really important, one of the questions that came to him is, how do you become proficient in what you're doing? And as we're training students, the one take-home message that everyone must do, two things. We always rely on our eyes, but don't forget to train your ear, because that often is more sensitive than what you see. And secondly, always perform the exam in the same way. Some people, they're just really not focused. When you do it the same way each time, you're going to recognize some of the small nuances that you didn't see before. So those are my take-home messages. Thank you.
Thank you so much, Diane. Now we move on the way to Europe with the European College of Phlebology representative, one of the biggest experts on the field, Professor Wittens Cheese. Can you give us your perspective?
Yes, absolutely. First of all, I would like to use the opportunity to thank you all. It's a great performance what you all did. And I also want to share a little bit, a few things on the questions that were there. For instance, there was a question related to if you can you predict a iliac vein obstruction when it's going to be to create a DVT. And I think I want to state, and it's a very important take-home message, that you never, ever do a preventive stenting or to prevent the DVT, because we never know when that's going to happen. So only for symptomatic cases. The other thing which was mentioned about in-stent stenosis, what to do with it. I only want to say that if there are no complaints, we follow them up on a 3 or 4 week basis and see if it's progressive. If it's progressive, we might do something, and when they get complaints, we do something. But if it's not increasing or decreasing the diameter, then we leave it as it is and we keep them on anticoagulation. And I hope that everybody now, we know that we need a measurement to predict for if a stent stays patent, which is most of the time related to inflow. We do for years and years already, we measure the flow in the common femoral vein, and we don't have any data that we can say, okay, above that amount of so many mils a minute, and that it will stay patent and that will not. But I hope that everybody will do that, and that we have an opportunity maybe in the future to gather all that information and see if we really can say, let's say, if it's below 100 cc's a minute, then you don't need to stent it because it will occlude. But we don't know that. Taking it back to the take-home messages, well, I think, and that's already stated, that of course the duplex is technician dependent, and the technician needs to be trained very well. And in our opinion, in our country, a lot of people who do duplex call themselves an expert, and unfortunately they are not. And they come up with outcomes that are not very helpful in deciding who to treat, yes or no. The other thing which is also mentioned, I think if you see an obstruction in the iliac vein, and if it's reversible with Valsalva, or when you put the patient sitting up, then it's not relevant. And I think the trick which Stephen mentioned about the 40 millimeter balloon pulling very slowly through it without any resistance, whatever you see on IVUS is not relevant. Whatever you see on duplex in that case is not relevant because the vein is big enough to augment the flow which you need. And that's the same for IVUS. We do it all in supine positions, and we need, in fact, a method to also be able to see it when the patient sits up. And we tried a few times with IVUS to see a stenosis, and you ask the patient when they are not under general anesthesia, you've asked them to sit up, and you see a very nice dilatation. And you had, let's say, more than 70% stenosis on the IVUS, and you have them sitting up and it disappears. And those things really need to be addressed. And I think the most important thing for me is that we can talk about diagnosis and we can visualize stenosis and we say, okay, this is nice that we see it, but for if it's clinical relevant, we never know. And we need to combine clinical signs, symptoms, diagnostic findings before we decide to treat patients. In our data, we are very, very precise, and still we have patients with iliac vein obstructions, so nivels, and we treat them by stenting, and they are perfectly patent. They have a very nice flow, nicely, let's say, structured stents, but 20% still have the same complaints. Why? Wrong diagnosis. And I think that's crucial. And that, as Nikos also mentioned, inappropriate care, money-driven care, unfortunately, is still out there. And this is an ideal point of pathology. 20% of the people have it, so you can treat anybody and earn a huge amount of money, but it's really a little criminal that you do it. And we have seen papers on 80 years old people, 90 years old people for varicose veins being stented because there is on the IVUS the stenosis. Well, I think that's really, really money-driven care, and we should get rid of it. So I think most important is it's good that we improve our knowledge how to visualize pathology, but we need to combine it with the clinical signs. And if there's no clinical sign, never ever treat whatever stenosis you find. That's my wrap-up.
That's a truly honored chair performance. So thank you so much. I will take this chance, since we have such experts, to make two questions by myself. One is for Nikos. We have heard the importance of the position of the patients. Do you think, or is it like already so, that we could create a sort of standardized protocol for which the patient, for example, could be assessed in supine and then maybe walking, moving, and then go back for a second assessment? So we see this variability. Would have that be something with a meaning or not? And the question for Steve I would have is about inter and intra-observer variability of IVUS on iliofemoral tract. I'm aware of data on the cardiological part, but not so aware about the iliofemoral part. So where we stay with that, and what is your opinion? So Nikos, you'd be the first.
Yeah, very good question. I like to echo the comments done by Dr. Kees Wittens. Kees, excellent. And I think with this, you address a lot of the questions that people had, already online. What I want to say with the position, we learned about 7 years ago, accidentally in one of our patients, that the positional change can change the diameter of the vein. Since then, I've been checking patients, and I can tell you, 6 out of 10 times, the stenosis significantly reduced or disappears completely. So I will agree totally with Kees that, these patients with a nivel, not the post-robotic, the nivel ones, to be studied at least in the semi-erect or standing position. You will be very surprised to see what happens, like the image I saw you. Now, I tried to persuade my colleagues, actually I mentioned to Steve some time ago, to see if we can use IVUS to do this routinely for the nivel. And if the IVUS proves exactly what the regular ultrasound does, maybe we should rethink of how we should treat these patients. Because I strongly believe many of these people, they just have a postural change and should not be treated.
I agree with that, Nikos. All those points are very valid, and I think if there's one thing that everybody should go home with is, disease is not about having fancy tools or everything else. It's about treating the right patients with the right symptoms to make people better. It's not about going to find lesions to treat because you can find them on a picture or an image. It's about symptoms first and foremost, and doing it in the right way. And over-treatment is probably the biggest danger we face in any specialty is inappropriate over-treatment of patients. Your question about inter-observer variability, I'm not sure any specific studies have been done with IVUS to look at that, but there's no doubt that, you know, there's a wealth of imaging or data on duplex scan to show that there's user variability in ultrasound. So any technique like this is going to have more inter-observer variability. And, you know, it does take a long time to get familiar with IVUS and be comfortable that you know what you're looking at. And that's why I use it all the time, because if you use it selectively, you're going to not pick things up. If you use it all the time, you get used to normal, abnormal, and everything in between. And you start to build up in your own head a good idea of images that you can refer to. If you selectively use it, then you're never going to be, you're going to miss stuff on the cases that do well. You're going to not see the things that do badly, and you don't have that that kind of image bank in your own mind. Undoubtedly, if we put it to test, it'd be broad variability. There's going to be user stuff. You know, it's an ultrasound-based technique. It's going to have variability.
And thank you so much. And now we are precisely at 90 minutes. So like in a soccer game, we will go toward the conclusion, not before asking Dr. Mina Sherian, our guest of honor, to say a last word, since she enjoyed this overlapping of the public health world she represents with the Venus world. So if Dr. Mina wants to say just a brief goodbye, because I'm sure we will have the chance to see you again in our Venus world. Dr. Mina?
Yes, thank you first of all for the excellent presentations. And even though I do not do ultrasound, but my interest to stay for so long was also to understand that how this needs to be, an awareness needs to be created in the public health domain, because it is so important. And I know these are all the experts, clinical experts, but me being an anesthesiologist in my past life, I feel that how can we make this applicable? Of course, your clinical work, which many people are teaching ultrasound in the low and middle income countries, but how can we as a group also talk about it, the implications when it's not treated, you know, as public health issue.
And thank you so much, and I look forward for seeing you all in person. I will conclude as always with the family. So Oscar and Willie, if you want to say goodbye to next Sunday.
Thank you, Sergio. I strongly believe that everything has been already said. It was my pleasure to share time with you, and I expect seeing you again next week. Thank you.
Willie?
Great lectures, great brainstorming session. I think that the take-home message is that there's still a lot of things for us to do, particularly on the education end. And thank you for spending the Sunday with us.
And thank you again. So we will see you next Sunday. It will be a hot topic, superficial venous procedures, with huge names, including Professor Kabnik. We will have Professor Kilnani, and we will have Professor Urbanek. And then I take this chance to thank once again all the ones who have made this initiative possible. And I deeply thank the two huge keynote speakers that will be, I'm sure, so nice to answer to all the questions we haven't answered so far in the different languages during the week. So we will reply to that. So once again, thanks to all the more than 1,000 attendees we had in between Zoom and the live on Facebook. And I look forward for seeing you next Sunday. And I'm also happy to say to you that we contributed in this way to humanitarian support to food projects that we will report on October 16, World Food Day. Thank you all from the bottom of my heart. Thank you.
Thank you. Thank you so much. Yeah, bye-bye. Thank you. Bye.